Welcome back to the conversation on cannabis and aging with Dr. Janice Makela and myself, host Dr. Riley Kirk. In part one, we covered a ton of different topics, and now we're going to keep the conversation rolling. We're going to be answering a lot of questions from the community because there were more questions on Patreon than we've ever received before. So I hope that you continue to vibe with us, and I encourage you to check out Dr. Makela's additional resources on LinkedIn or on her website if you have additional questions or want to learn more about specific subjects. So make sure you take a sip of your tea, lean way back in your chair, moisturize with your favorite topicals, and just chill with Dr. Makela and I for the next hour. On a similar note, just talking about, drugs and how they interact with the body, another thing I've noticed with a lot of conversations with elders is for sleeping, for using cannabis for sleep, it almost seems like a lot of elders are almost more comfortable taking a benzodiazepine and not scared of that, but they're very scared of using cannabis for sleep. And I don't know if this relates to stigma. I don't know if you see this in your practice, but it's something I'm always honestly a little bit shocked about because benzos honestly scare the crap out of me. And I feel like they should scare more people.
And benzos, you get a lot of people who still have to take their benzos because their doctor started them in the 1970s, 1980s when we didn't have SSRIs. And now they are still very much have to take their benzos, or you're trying to get them off them, and it's very difficult. But the benzos, they increase falls. And then what else are people using for sleep? Now, I have to admit, I've used trazodone, and the data, every medical organization comes out, because I'm just one of a handful of docs many docs who prescribed trazodone for sleep. And, so all the medical organizations are coming out and saying, you should not use trazodone because it's an antidepressant and it's not approved and it's not necessarily good and it can increase falls. And they're probably right. The other thing that I see some people using that scares me a little bit is antipsychotics.
Interesting. I thought you were going to say alcohol, but antipsychotics too. I mean,
or
the combination. Yeah.
Well, so for me as a geriatrician, I will get people with dementia who have behavioral and sundowning. Now, the sundowning, I will give if they're hallucinating, if they're really acting up, they might need an antipsychotic. There's a couple different ones. My go-to often is one called quetiapine, Seroquel, because it doesn't have as much dopamine, so there's less chance that if they have Parkinsonism. Other people might use olanzapine. And then there's one now that's actually FDA approved. Expensive because it's FDA approved, but there's one that's, and so when people have trouble sleeping because of behavior, it's one thing. But then because it does make you tired, especially the Seroquel will make you tired, there are some docs who just use it for sleep. No, you should not just be using it as a sleep drug. But the point of all that, of saying these are the drugs that are out here, and an Ambien.
Right. Ambien is one I see all the time.
Right. And Ambien. Oh my God. Ambien people will wake up in the middle of the night and drive their car, or it happened to my dad. He took Ambien and woke up the next morning, found his leftovers were eaten.
My mom bought like a bunch of hats on Facebook Marketplace, like when she was on Ambien. Yeah, and she just had all these messages she woke up to, and she's like, I have no recollection of doing this.
Yeah, he had multiple nights where he woke up and he realized he ate all his leftovers.
Oh man. And he's like, man, I just not vibing with breakfast anymore. I just don't need it. And it's like, you've been eating 1,000 calories every night.
So Ambien's not terribly great. It has a lot of side effects with that, and it can make people very tired. And then God forbid anyone grabs over-the-counter stuff that has Benadryl in it.
Right.
Oh, dear Jesus. Before all those other things came out, I was getting so many people. I remember about 20 years ago, before we had Ambien or any of these other ones out there, that I'd get consults as a geriatrician, say, help with the delirium. And I didn't even have to look at the chart. I'd just tell the resident who was telling me about it, I'm like, how much Benadryl did you give them? You know?
Wow.
Yeah,
So
because it would make them nutso.
It's almost like every sleep medication seems to have some sort of side effect because it is, knocking you out to a degree. So would you say that like cannabis using THC or CBN is a safer alternative for elder people compared to some of these other drugs that they're on?
You know what? CBN, the data on CBN is a little bit weak. And it's kind of like probably the only safe-ish drug out there is, we didn't mention it, was melatonin, right?
Okay.
Yeah, right. But melatonin doesn't work great. It works for some people and doesn't work for others.
Could be a good starting place though, as if it is the safest, be like, try melatonin first and then try something else.
Right. And so I would say I would do melatonin, and then I might try CBN because the data shows it works about the same as CBN. They both work better than placebo. So I would suggest trying a CBN if melatonin doesn't work.
Okay.
And then, interestingly enough, some of the stuff about CBD I was reading suggested that taking it at bedtime doesn't help because it kind of amps people up a little bit.
I've seen data that it can be dose dependent too, where the lower doses of CBD can be stimulating, whereas the higher doses can be more sedating.
I saw that same thing, that the higher doses. I saw one study that suggested that CBD in the morning actually helped because, like, if you had people with anxiety or pain or something like that a morning dose, that people were actually taking the CBD in the morning and it was helping them sleep at night because the anxiety and pain was still being controlled in the evening. Now, THC can help some people. Some people, I think, can also be kind of wide awake when they take it. Another weird thing is it can help with sleep apnea.
Interesting. THC can help with sleep apnea.
Well, the study is in dronabinol. In fact, I personally think that what's happening is dronabinol, which got bought by another company, they're trying to make a combo pill of dronabinol with acetazolamide. That study just came out. And why are they making a combo pill? Because they can patent it.
Interesting.
I'm convinced of it because dronabinol is out of its patent now. And so...
I like where your brain's at. Always ask questions. That's really interesting.
Right? I guess, that with THC and sleep, to get back to your point, I think primary insomnia, the data's really not as strong of it being as effective. I think there is some people who benefit, but I think long term it kind of throws your sleep architecture off a little. And again, here's the thing. If you have PTSD and you get nightmares and you can't sleep because you're waking up with nightmares, taking THC might help you block those nightmares because it inhibits REM sleep.
Which can be amazing, that you don't because not everyone has pleasant nighttime dreams. Some people go to a really negative place. Right. It's really important to say.
And, when I've been asked about it for trauma and things like PTSD, the other thing I'll say is you have to be careful. You want to make sure that you're not using it to hide from your trauma. You want to use it in conjunction with some cognitive behavior therapy or EMDR or some sort of therapy so that it's working synergistically together and you're not going into a point where you're just getting yourself wasted and stoned every day.
Don't use it just for escapism. I mean, you can use it short term for escapism, but not forever. It's not sustainable.
It's not but that's where PTSD can help with sleep. Pain, of course, we talked about already. But that said, in the realm of things, with all that caveat, given all the drugs we just talked about with all their side effects, I do believe that THC low dose is on the table for people who need it. It's at least should be a discussion point.
Seems like cannabis is always under a microscope, where if there's like one thing that happens, everyone's like, it's so dangerous, nobody should be using it. And then all these other drugs, it's like, yeah, that person, jumped off a balcony, and this person, drove their car to work at 2 a.m. But, we'll ignore that because it works for most people. But with cannabis, we put it under this, extreme microscope.
Well, that's it, is that, I mean, take statins. Now, please understand, as a regular doc, as a regular allopathic doc, I love my statins for people, right? And anyone I love who has a bad heart, diabetes, risk factors should be on a statin. But 1 out of how many million people get really bad rhabdomyolysis to the point that their kidneys and liver can fail?
Right.
How many millions of people, and if you're that one person, that really sucks. Now, if that happened with cannabis, people would be all over it. There'd be,
We'd see CBS release a story tomorrow about it, front lines, and nobody should be taking this. Everyone should be scared of it.
Right. I mean, and we just say, what, there's millions and millions of people whose lives are saved by statins. And so we take that chance that you might be that one bad person,
Yeah.
because the chances are low. But like you said, if that happened with cannabis, we'd be like,
Yeah.
I personally take a view of, in medicine, when we talk about things that we don't have a lot of research. You see this when we talk about prostate cancer. So prostate cancer, it used to be a no-brainer. We'd do a PSA. If it's above a certain level, we're going to do a biopsy, right? Well, what they found was we were actually harming a lot of men by doing that. Because, first of all, the biopsy wasn't necessarily benign. That was a surgical procedure. Second, if you did find cancer, there were some cancers that were going to never kill you if you lived to 110. And then there were some that were going to kill you rather rapidly. We didn't have a good way of telling those apart. And then you add that to the fact that we now had drugs that could buy you 10, 15 years. So if you're 85, you're going to die of a heart attack before you die of the prostate cancer you have. All of those things combined cause doctors to reevaluate and say, does it make sense to be screening for prostate cancer like we do with mammograms with breast cancer? And they actually came out and they said, above the certain age, yeah, you probably shouldn't be, because the, a 90-year-old and 85-year-old screening for it, they probably have the prostate cancer that is not even going to kill them. And even if they don't, you give them the medicine and they'll live 10 years and die of a heart attack before they die of the cancer. But that younger population, there was this kind of in between. And they said, okay, a younger population like 60, 65, especially in African-American populations, yes, you should screen. But there was this middle population. And so they used the term, I want to say joint decision-making. And maybe for cannabis, that's the term we should use.
I kind of love it.
Right? Joint decision-making. But it's like collaborative decision-making or something like that with your doctor, where you look at for the individual patient, look at the risk and benefits and discuss with your doctor as to whether testing a PSA is right for you. And that is sort of the way in medicine, when we don't have a good answer, that we use to describe saying, you know what, talk with your doctor and you make a decision, and it's on you guys. It's not on us. We're not going to make a decision. We're not going to say one way or the other.
Seems reasonable to me. I feel like that's how most decisions should be made.
Right? But when it comes to cannabis, we never do that.
No.
We were, even stuff like the sleep apnea, something like 7 out of 8 studies, 6 out of 7 studies showed that dronabinol helped with sleep apnea. And like I said, I think they were trying to get FDA approval, but then their patent ran out. So now they're redoing it with a combo pill to get the new patent. No joke. Honestly, I think that's what's happening. But you have, even though there's a lot of data to suggest it might help, you have a lot of organizations saying, oh, no, you don't know the long-term effects. We don't know if it's going to help. We don't know really how much I'm like, or another time when we had a study, to be fair, it was a phase 2 study, and the world is littered with phase 2 studies that once we did phase 3, found out it didn't help. But there was a study of Stativex with and without a drug for brain cancer in glioblastoma multiformes, the worst brain cancer, right? In people who were intractable, incurable, they gave them a course of the chemo for palliative to try to buy them more time. And then they gave them the course of, and I say chemo lightly, it was actually like one of the MIBs or MABs, and an oncologist would say that's not a chemo, right? They would give them a drug with the Stativex, and the people with the Stativex lived twice as long.
Oh, that's pretty substantial.
It was several, like months longer, like twice as many months longer. And there was a little bit of quirk that there was early on some people in the placebo group that died, just died. And they don't know if that was the BMJ, British Medical Journal, actually put on an editorial to basically say, whoa, docs, don't be giving people cannabis who have brain tumors just because of this study. It's still early, and it's still hold your horses. I wish I could say it was more measured and more like, hey, let's wait till the phase 3, be very careful. We don't know what the no, it was like, we don't know that it did cause dysphoria and, all the things of being high, right? You understand that when you're dealing with intractable cancers, people put up with drugs that almost kill them. I have seen people in an experiment for melanoma, for metastatic melanoma and metastatic kidney disease, when they were trying the interferon in the early days before they had the MIB and MAB drugs 20 years ago, where they would wind up in the ICU after the treatment with severe stuff, but that was the gamble you would take to try to cure the cancer.
The side effect of feeling high over almost dying pretty much any day, I would assume.
Right. And so it's just like, if anyone I loved had brain cancer, and then of course you have all the anecdotal reports of people on RSO and stuff like that aren't great studies, but
millions of people, have these stories to tell. So I do think it matters.
It kind of builds up. You have a case report is when a doctor says an anecdotal report. A case series is when a doctor has several anecdotal reports. And I think we're really in case series levels of this, where there does seem to be some evidence that taking cannabis and brain cancer, again, am I saying this for sure as again, caution, but this, oh my God, you can get high, you could fall, you could do, it's cancer, folks.
You might be sitting or in a bed anyway, so falling might be a less risk, and just improving quality of life and improving how much you feel like yourself. And if you can laugh, and if you can talk, and if you can do these other things like that, those are really important outcomes that we often aren't measuring as intently as these other things that you're discussing.
And I guess that's kind of that bias that you're talking about, that, oh my God, it's cannabis, really does kind of get to me. It's like, come on, guys, it's a medicine. The endocannabinoid system is real. It really is a real thing. Even if we never use cannabis, I'm going to go on my soapbox for a second.
Please
Pardon me.
Yeah, I'm cheering for you. Let's go.
The endocannabinoid system is real. Even if cannabis never existed, we have an endocannabinoid system. The fact that we don't research it as much now, yeah, there's some researchers in the PhD world, but medicine, it's not getting transitioned into, this is a drug, this is how we do it, this is how cannabis works on it. The fact that there's this bias, maybe because it's called the endocannabinoid system, we kind of freak a little bit. That's a colleague of mine in Sweden who researches it. That's his belief, that the name is creating the bias. But
it's not a bad theory, honestly.
Right? And now we're just, this is how you get high. And I'm like, no, this is how maybe you could prevent Alzheimer's, schizophrenia, diabetes, obesity, heart disease.
I feel like that's part of the stigma too, or like why medical professionals might not I'm going to use quotes here, believe in it, is because it helps with so many things, and that they don't understand what the role of the ECS is in the body to bring balance to these other systems. They think that it's just like stoners being like, oh, I use weed to help with anything because that's just the medicine I choose. And it's like, no, like there's a lot of validated pathways here, understanding that this system is meant to bring regulation to dysregulated systems. So that's why it can help with pain and appetite and mood and inflammation and all of these different things.
When I first started learning about the endocannabinoid system was when I had to give a lecture about pain. And I learned that the inhibitory pain pathway, there's a pathway in our body that shuts down pain in extreme situations, right? If you're running for your life from something trying to eat you, or if you're a soldier fighting in a war, it will shut down pain because evolutionarily it is better to not die than to feel, so you shut down the pain so you can run for your life if you sprain your ankle, right?
Glad that exists. Yeah.
Right. And if you've ever saw Forrest Gump where he gets shot in the butt and he's like, something bit me. He's not even aware he got shot. That is a very common phenomenon because the adrenaline is one of the things that will shut it down in our body. But opioids work on that pathway. But the very first step in that pathway is the endocannabinoid, the CB1 receptor that triggers it. And that was one of the first times. The other time I heard about it was when Recombivant first came out. A friend took me to a drug rep dinner, and I was young enough of a doctor that drug rep dinners sound like a great idea.
Oh, God.
And they were still they were still common at the time. And they couldn't name the drug because it wasn't FDA approved, but they're like, we wanted to teach you all about the endocannabinoid system. Why? Because they had a drug coming. And that's the other theory I have, is that the endocannabinoid system isn't being taught because there isn't a drug besides cannabis that is being made for it yet. The minute
and they've tried, and it's always had so many more detrimental side effects compared to cannabis because they don't understand that this system, if it does control everything, that if we try to mess with it in the wrong ways, that can lead to some pretty serious adverse effects, which I'm sure you're familiar with Ramonabant for, obesity, I believe was why they tried to release it. And, it did work. It made people want to eat less because it was working in the opposite way that, essentially THC does, or your endocannabinoids. But what they didn't realize is that this system controls everything. So when you just reverse the way that receptor acts, you're also going to affect things like appetite and mood. There's a lot of people that tried to commit suicide or that were suicidal in general.
Right. It also had a couple of cases where people had latent MS symptoms suddenly pop up. And I mean, MS is a classic example of the other way where people have broken endocannabinoid systems. The mouse model, you break the CB1 receptor with something genetic or whatnot, right? And it's not surprising because we know the CB1 receptor is involved in creating myelin in the brain. So MS, where you have problems with demyelin, and then of course immuno issues, right? So autoimmune diseases. So MS.
So you can't just isolate like what the CB1 receptor does. You can't be like, I just want this to work for appetite. It's just not the way our body works. There are some community questions, and I really want you to get your answer on a few. Okay, we'll start with Jacqueline's. And she asks, for folks in institutions, I would like to hear the approach to navigating the regulations and resistance, since loss of funding is profoundly impacting our elders. I would also like to understand beyond recommendations, the partnerships with other professionals in the successful management of patients and how the team documents successful outcomes and is targeted de-prescribing one of the objectives. Beyond cannabis, what approaches are being successfully implemented in targeting the ECS?
Ooh, you had a few questions there. Okay.
Yeah.
So the first one about institutions. Institutions are really hard because it is federally illegal. A lot of institutions, especially those that take Medicare, just have absolute rules if you can't use it.
Right.
I run into that in hospice. I would love to have a little tincture of cannabis be in my comfort pack. I can't do that. I told the hospice owner, the hospice that I'm the medical director of, I said, we should advertise that we're canna friendly. He's like, we can't.
Oh, that would be that would be
Right?
amazing.
We're
If
we're a
you're able
canna
to.
friendly hospice, but we can't because we take Medicare money. And so a lot of nursing homes and facilities take Medicare money, and so they can't use cannabis. One workaround I've talked to some people is because of as long as it's still legal, and they might be patching it up, as long as the hemp rule is, you might be able to get hemp derived THC in it, but you're still really going to be fighting an uphill battle with the institution, I think, with that. But I have heard of some people having a little bit of luck with that. And now the second question they asked about was deprescribing. So we've seen data to show that in states, whenever there's legal medical cannabis, that the deprescribing, that less and less opioids are being used and less of a lot of different anxiety drugs and other things are used because cannabis does seem to be helping with that. So, yeah, I think cannabis can help with deprescribing. Now, it's deprescribing in general as a geriatrician, big fan of that because there's a lot of too many drug interactions. There's a lot of data to show that people, when they have drugs that interact, they get worse.
Yeah.
And then I think the third question they asked was,
Beyond cannabis, what approaches are being successfully implemented in targeting the ECS?
you know what? Beyond cannabis, omega-3.
Ooh, love that. As a
Yes,
supplement.
right. Omega-3, omega-6. Now, personally, I joke a little bit that it's the fish entourage effect because there hasn't been a single study to show, except for like the high dose Visipo stuff, that omega-3 fish oil supplementation decreases heart disease, but fish data does. Now, what it's turning out is that so omega-3, omega-6, and omega-9 all become fatty acids in the body that then act on the endocannabinoid system. In fact, omega-6 actually becomes, I want to say it actually becomes anandamide. There's a lot of doctors who research, a lot of researchers, PhDs and stuff researching this, who will say that our diet with the very heavy omega-6, this is the grain of truth behind the seed oil people. I am not a ban all seed oil person, but the grain of truth behind that is that oils with high omega-6, there's so much of it in our diet of omega-6 that the omega-6 to omega-3 balance really matters. And the American diet has a 1-to-20 omega-3 to 6 ratio, whereas it should be 1-to-4 or 1-to-1.
Dang.
I mean, you need omega-6. Again, you can't just ban it. A little canola oil is not going to kill you, but
a lot of canola oil isn't necessarily good for you.
Right, and that's it. It's that ratio of 1-to-6, and canola has some little bit of there's some of the other oils are worse than the canola in that because it's a scale, right? How much does it have in it? Now that ratio matters though, and there was a recent study to suggest that the ratio matters more than just the amount of extra omega-3 you take. And I think what happens is when you look at your Mediterranean diets, which are very well balanced in your 3 and 6. I mean, and again, this brings it back to standard healthcare. I'm not talking voodoo. I'm saying this is why the Mediterranean diet works.
Right, food is medicine. I actually have a published paper on the Mediterranean diet that I'll put in the show notes of this episode, talking about how it leads to longevity and flavonoid content and all that stuff.
Right, and so the Mediterranean diet, that balance of 3-to-6, if you're having 2 servings of fish a day, what you're also doing is you're not having omega-6s. So I think that's why taking extra fish oil doesn't help. You have to also decrease the amount of omega-6 in your diet.
So you're saying you have to change something in your life instead of just supplementing and supplementing and supplementing?
Yes. I mean, but that's the argument behind the Mediterranean diet, right? I mean, the DASH diet, and particularly the Mediterranean DASH diet, does not taste very good. But the Mediterranean diet, and this also means, they look and they say the Scandinavian diet, again, very heavy in fish and herring and stuff,
and just whole ingredients in general, like less processed. A lot of processed foods have that ratio is really off. And, as you're saying, the more that we can supplement our body with this correct ratio of fats, that's going to help us build healthy membranes in our body, build endocannabinoids, build other fat signaling molecules. That's what our body runs on. So we're providing it with more starting material to produce these really important compounds. And I will say, beyond fish oil, hemp seed oil is also a great ratio of omega-3 to 6.
Flaxseed also is amazing. So those are some of the other things. So that omega-3 versus, I always throw a handful of flax in any baked good I do, right? So the 3 to 6 ratio, I think, really does make a difference. And then the other thing is that, but again, the 6, it's interesting because we talk about building stuff. They actually, the people I've talked to with 6 actually say it's putting us into overdrive. It's actually making the endocannabinoid system go towards inflammation.
Interesting. So almost pushing towards dysregulation instead of regulation. It's
pushing towards dysregulation when you take too much 6, because all that anandamide just is too much for our body. And it's overregulated, and so we're drowning in the endocannabinoid system. Back to the heart thing, one thing that's never been looked at is the interaction between this and people and smoke. Is the heart thing actually someone who has an inflamed omega-6 body now using cannabis? Is that playing badly? No, there's no data on that one. It's just a question I pose. But that idea of the 3 and 6, I would like to see that a little bit more looked into, a little bit. I want to see that on food labels, actually.
I agree. I think that would be super valuable. And I'm sure, as you get older, at least from my family members, they tend to eat a lot less when they're older. So maybe they're not getting as many of these healthy fats that they need, and they're not able to, build enough of these molecules. So
and that's possible too.
May help. Yeah.
And then, that's the whole thing. You talk about dysregulated endocannabinoid system. A lot of diseases, I think, like I said, MS being a classic one, are things where you don't have enough of it, or it's not responding to it. Your receptors are broken, so you may have enough, but they're not reading it. And I think learning about this balance, learning that there are people who have too much and they need a better diet to help with that. And then there are people who don't have enough because of a disease system. And then kids. I personally think that when we talk about kids using cannabis and, oh my gosh, they can get schizophrenia and stuff, I don't think that's all fear mongering. I think a lot of people who say I took it when I was 14, and now are 40, we're taking a very lighter dose, different. These higher doses cannabis that is out. Not to mention, remember, a lot of these kids are probably getting it from the street too. They're not necessarily getting, you'll be lucky if they're getting it from their mom's stash.
I started using cannabis at 14, but to your point, the cannabis I was using at 14, didn't even smell like weed. It looked like hay, and it was not quality cannabis. It certainly wasn't this 25, 30% THC cannabis that some people are using. So, that definitely could be a factor too.
And I think, but what's interesting is you talked about back to those omega-3s and 6s. The schizophrenia and the pruning. So in your late teens, early 20s, your brain goes through a process where the white matter increases, myelination, right? The fat on the nerves increases, and that's called myelination, and it's important. And then you also have what's called pruning, where a lot of these nerves that were useless from childhood, get pinched and removed. And so that is the process that your brain takes to be between becoming an adolescent child and becoming a full-grown adult with a more common sense brain, so to speak. That last stage of development of the brain, right? And we see that, the adolescent brain versus the brain of someone in their late 20s, right?
Oh yeah.
Schizophrenia happens around the same time of that process. And there's actually, I did a little deep dive into it. There's a lot of evidence to suggest that the endocannabinoid system is responsible for this process.
This is fascinating research. I've dove into this too. I'm so glad you're talking about this.
Yeah, right. And so it's like the ECS actually controls that. And so schizophrenia is probably when you have a genetic tendency for that ECS process to mess up. And when it messes up, you get schizophrenia. There's actually some studies in people who are high risk because their parents had schizophrenia where they gave them omega-3 fatty acid and prevented schizophrenia, or at least prevented a lot of the psychosis. They might have always been, but they weren't as bad as they would have been.
The symptom onset that we associate with schizophrenia.
Right, right. And so they had a lot less psychosis and a lot better behavior. Now, and then there's a couple of data, and it never went too far beyond these first studies but they compared CBD, a fairly large dose, about 600 milligrams, to an antipsychotic, and the CBD did as good as the antipsychotic in treating schizophrenia without as many side effects. But it was like 1 or 2 studies, and then it just kind of disappeared. We stopped seeing the data on it.
I don't know why any of these studies haven't gone further, because there's even data. I mean, there's data that people who are prone to schizophrenia, whether that's genetically or they've shown symptoms, really gravitate towards cannabis as well as like a medicine, because there's also linked data that people who are schizophrenic have lower levels of endocannabinoids, which, to your point, supplementing with the right fatty acids or even CBD or something else that can help kind of regulate the system could be beneficial. But because this topic is so stigmatized, I think funding is just at zero. I don't think we're ever going to get funding. I shouldn't say ever. We will someday get funding, but in our current infrastructure, we're not going to get funding for this. But there's a lot of information and data showing that the ECS is linked to schizophrenia, not necessarily that, THC causes schizophrenia. I hate that, because it's not like a common cold. You don't just like catch schizophrenia, but if you are genetically susceptible, it's absolutely linked to your genetics involving the ECS. And this is a huge piece of the puzzle that we need to be studying more.
100%. Because I want to see kids who are, I want to see testing. And if you are at risk for it, you should be taking omega-3s.
Yes, I love that.
The other thing I would say, though, right now, given the current lack of knowledge, is this. I think there's a fair argument, and I do agree. I've talked to some psychiatrists who say there are some people who seem to self-treat with cannabis, and they actually do better. When they try to take them off, they get worse, and and they're like, okay, yeah, no, stay on it. But again, schizophrenia is a genetic polymorphism, fancy term, meaning that there's several genes that could be causing it. Gene A, gene B, gene C, and depending on which one is going to present how you present. So I think there's a subgroup that is self-treating and does okay, and that's something that the psychiatrist and them need to handle. That's beyond my pay grade and understanding of it. But I think it's fair to say that until we know more, there are people, schizophrenia is a range, your risk, from everyone to someone who's going to be floridly schizophrenic no matter what, to someone who's going to be just a little off. You're like, you're a little off, but I don't know why, and to someone who doesn't have any symptoms, but is, genetically is a little bit more at risk, to someone who has no risk. And so someone who has no risk takes cannabis, they're not going to have a problem. That it's that person who's either having a little bit of symptoms or no symptoms or just above that low end, that now you take cannabis and maybe now you kick them into schizophrenia.
Yeah, and there's data that shows that it could present earlier if you are genetically susceptible to schizophrenia. So instead of, say, the onset age being 27, you might experience that at 24. So using cannabis could push it earlier than when those symptoms would have presented if you were not to use cannabis.
Right. And so cannabis might make this, and it might make things worse. And so it's possible that it's messing up this process. And since this process is a permanent thing in the brain, that there is some data that the cannabis psychosis can be long-term, and so the question is, the message I would say to kids is, I'm not trying to bogart the good stuff from you. Mm-hmm. This isn't us being adults smoking joints and saying, oh, you're a kid, you can't use it. This isn't a rite of passage to being an adult. This is a point in your life where it is dangerous. Potentially, it's Russian roulette. Maybe you're fine over here, but until we have like a good test or something, we have no way of knowing.
Yeah.
To say, and I don't think anyone's going to make the test because no one wants the liability of someone getting psychotic when their test said they'd be fine. I
don't blame them for that either.
Right.
It is a delicate topic, but again, thank you for bringing that up. It's delicate, but like there's so much nuance and there is research on this. I think people think we have no research on this topic, but we do have some very interesting research to at least
we do.
Start.
And I know it's not our geriatric population. It's quite the opposite. I will say this. If anyone out there is a pediatrician, a psychiatrist in peds, and deals with cannabis psychosis on the regular, the study I want to see done, and I can't do because I'm a geriatrician. I'm an adult doctor on the other side of the ed spectrum of life. I can't do this study. It's not my patients. I want to see what happens if you have someone with cannabis psychosis and you give them omega-3 supplementation. Do they get better faster? Right? Because we know it helps prevent it in people with schizophrenia. So if someone now is manifesting,
could it be a reversal?
Could you speed the recovery, over and in addition to what antipsychotics do? Could you speed the recovery, maybe help them not be permanent if you give them some omega-3 or CBD or both, right? And see if that helps them recover again. Or if you have someone who has cannabis use disorder at 13 and is using, if you say, okay, in the meantime, while we're getting you treated, I want you to take omega-3 for the next, year supplements. Can that decrease their risk of developing cannabis psychosis while you're trying to get them? Yeah. And those are not studies I, in my field, can do, but I put that out to anyone who is studying it.
It's a good audience to put that out to, because there very well might be someone listening, or maybe someday, us through our nonprofit can do that research. Quinn S. asked, my mom and her friends used to drink a lot, and now they're using cannabis instead of drinking. Do you see any outcomes in elder populations that choose cannabis over choosing drinking, specifically for memory or just brain health in general?
I think the data about drinking, drinking is actually pretty strong in the negative,
Yeah.
Over the years, they used to say like 2 glasses of wine were okay for you, 1 glass if you were a woman. And now they're even backtracking from that, And I think we do see a lot of older people who use alcohol because they're bored and start drinking way too much. And that can cause liver damage. That can cause memory damage. You do get memory damage from excessive drinking. So that in perspective, replacing something bad with something else. Now, cannabis, just because you're replacing bad doesn't mean this is good. But in the realm of things, there is some question about long-term use with memory, like over the course of time. But then there's also some thought about neuroprotection that might be actually happening with Alzheimer's and stuff like that it might protect. I think you have to be careful. You want to make sure you're using low doses. You're not putting yourself at risk for falling. You do be very open to your doctor about your use recreationally. And, so you can look for drug interactions. You be very open to your doctor, be very open to your doctor. Make sure you're using low doses. Be aware that tolerance can develop. And so then with tolerance, people are taking more and more. And I think that's one of the things I worry about a little bit when people self-treat, is that they're not as acutely aware. Whereas if you go to your doctor, you're like, oh, I don't want you to get tolerance. There's another doctor, Sulak.
Dustin Sulak, yeah.
Yeah, Dustin Sulak, he advocates, he created a protocol for what he calls a tea break, a tolerance break.
Yeah.
There's different variations of that. But you want to those are some things you want to be aware of. I don't think it's necessarily bad. I just think you have to be cautious and,
Yeah, that is an interesting question because it's much more recreational or adult use compared to medical, which we've been talking about. But last question is going to be from Free Range Mister. And he asked, Inflammation is the biggest problem for old folks like myself. Are there strains or differences between indica and sativa, or even different light colors to help with terpenes that could diminish inflammation?
First of all, the indica and sativa thing, I have yet to see any evidence that there's really much difference. And with so many crossbreeds right now between stuff, the inflammation itself, maybe like the CBD might be a little bit better for the inflammatory stuff. I would actually suggest trying that first for inflammation. And remember, as I mentioned, our diet, if you're very heavy in omega-6, is actually pushing our body towards inflammation. So decreasing the amount of omega-6 in your diet, increasing the amount of
inflammatory foods in general. There are some foods that make you feel inflamed. I would also add, you had a question about terpenes in there. Beta caryophyllene acts on the CB2 receptor, that's a terpene, and it's directly related to inflammation. So that's going to be your strains that smell really peppery or a little clovey. That can be.
There's a lot of people who swear by BCP as just by itself. I myself have not done as much study into the BCP as perhaps I could for all the questions I've been getting about it lately. I need to read more about it. But there are people who sell just BCP now as an anti-inflammatory.
Yeah. And, as you said, indica, sativa, those words don't necessarily mean a ton as far as research go, because most things are hybrids, but beta caryophyllene is very often in your more sedating varieties. So things that you might associate with indicas, or might smell a little more like sativas, smell much more astringent-y, much more uplifting. They kind of like open up your eyes just by smelling them. If you smell something that smells really earthy and clovey, those are going to be the strains you want to look for that typically do have beta caryophyllene in them. I think you've been just a wonderful guest. You've been so informative. I think you're going to help a ton of people. I want to give you the spotlight to talk about any courses, any ways that people can learn more about what you're doing, any way people can connect with you to, get more information, because this is so valuable.
So there's two things. One, I have a live stream that I'm doing. Right now, I have been doing it at 3 p.m. Central Time on Wednesdays on LinkedIn, YouTube, and Twitch.
Okay.
And they're all my channels, Janice Makela, MD.
And I'll put those in the show notes that you're easy to find.
And this month, actually, I'm going to start this Thursday. I'm going to do a 7 p.m. Central Time, because I realized that there's a lot of people. I've been getting a lot of industry people in my calls.
Yeah, or caregivers. I'm sure caregivers love the information you're putting out.
But right now I have 3 p.m. on Wednesday Central Time and 7 p.m. on Thursdays Central Time. And then the other thing I'm doing is I am creating courses for physicians. And so because I realized I can talk to 50 people, but it'd be better if I talked to their physician. I am creating courses to teach. Right now, I am creating them, and I'm asking any physician who wants to reach out to me to tell me what they want to learn. But in the very near future, within a couple months, I will be putting out a full course for physicians, where I'll be doing about a 4-week, 30-day. I'm not sure if it will be 4 or 6 hours, depends how much people actually need and want to know.
They need a lot, so we'll see.
Right?
I love that approach. I love that you're doing something to help educate the medical professionals, but also have this live stream and this open chat, whether you are a caregiver or you are an elder person who needs to get questions answered and you don't know who to go to. It's an amazing resource. So thank you for all the information you're putting out. And of course, thanks for coming on the show and giving your expertise.
Thank you so much.
Thank you all for listening, and we'll catch you in a couple weeks. Mad love.
Thank you.